Hi, my name is Dr. Qazi Javed. I'm a child and adolescent psychiatrist. I'm also an adult psychiatrist, and I wanted to talk a little bit about a topic that I'm very passionate about. And it is a condition that is poorly understood, both by healthcare providers and also by patients. It is a condition with not as much research behind it. Eh, since recently I was appointed on the Governor Abbott's board advisory committee for PANS and PANDAS, I decided to come up with this series to educate people a little bit about PANS and PANDAS. One of the most challenging things about PANS and PANDAS is usually the diagnosis of PANS and PANDAS, because until and unless there's a diagnosis, there is no treatment. So for a diagnosis to be made, there are certain criteria that have been proposed for it. And we'll go through those criteria just to familiarize ourselves with how PANS or PANDAS can present. So there are two major criteria, and either one of them can be present or both can be present. And one of the big criteria behind the diagnosis of PANS or PANDAS is the sudden, abrupt nature. And we'll talk a little bit more about what sudden and abrupt means. But one of the major criteria is obsessive compulsive symptoms. And these involve obsessions, which are intrusive, and compulsions, which are showed in acts which are recurrent. And then the other one is the problem with eating. There are minor criteria also, and any two of them, along with one of the major criteria, qualify for a diagnosis of PANS or PANDAS. And we'll talk about the difference between them also. So this is a fairly important slide because anxiety is one of those criteria that can be present in a child that suddenly changes. So whereas a child was perfectly okay, developing fine, now suddenly has difficulty even going to the bathroom alone, or separating from the parents to go to school. Emotional lability happens, meaning that children can suddenly lose control of their ability to regulate their emotions. When there's a small disappointment, there's a huge outburst. Children can become depressed. Children can become aggressive, irritable, and they start showing oppositional behaviors. And usually this is linked to the obsessive component of the illness, in which if parents want the children to do something, but a child is stuck and doing something compulsively, they will not move on. So there are oppositional behaviors, usually because of those intrusive thoughts. Children's school performance declines, their academics suddenly get worse, they can't focus on them, they're much more anxious and fearful about other things, and academics takes a backseat. You can see sensory problems, so not very uncommon is that some people, especially children, they change the texture of their foods. They change what they want to wear. Sometimes they go into just one type of clothing and they wear the same clothes over a year even. And there are motor abnormalities that can also accompany PANS, and these are typically shown in drawing of a child or writing of a child. And you can see the difference between a child whose writing was perfectly well, and after a flare or after an episode of PANDAS, their writing becomes fairly problematic. Sleep disturbances is a very, very common feature in PANS or PANDAS. Bedwetting starts. So whereas a child would be perfectly toilet trained, would start wetting their bed. And sometimes instead of the bedwetting, children start showing urinary frequency. So in a class or even at home, they feel that they constantly have to go to the bathroom, and all these symptoms can combine with one another. So, for example, some children, they feel the sensory problem with urination. They feel that they have to go to pee, but they don't. Or some children, they are so obsessed that they have to wipe themselves in a particular way, which can actually promote more disease. Some children who just cannot feel that they've cleaned themselves well enough, so they'll be taking showers and they'll be. So these are the minor criteria. So far we've discussed the major criteria, we've discussed the minor criteria, and one of the things that is most, as in medicine, we are starting to understand what this is all about. PANDAS is another word that is used. And since this was the beginning of us learning what autoimmune conditions can be after an infectious trigger, we started off with the streptococcal bacteria. Now, the most current thinking is that PANDAS is a subset of PANS. And PANS, we just talked about the various criteria. If it happens with a streptococcal infection, that means that a child had a streptococcal infection, and after that, a child starts developing the things that we talked about, the obsessive, compulsive behaviors, the restrictive eating, and the minor criteria that we talked about, then we call it as PANDAS. So. The challenges to diagnosing this are system-wide. The challenges are with the nature of the diagnosis itself, because it is a diagnosis that we are still discovering more and more things about. There are, even in the healthcare community, even in the physician community, this is a widely debated issue in which there are some people who believe that this diagnosis should not exist, and it is a catch-all for multiple other diagnoses. And then there are very reputable academic institutions that are using this diagnosis, and because it gives them a framework to diagnose and then treat. The interactions with healthcare that patients have or that parents of children have are problematic, because the healthcare people do not have guidance about what to do when something like this happens to a child. The perspectives of people in healthcare are different. As a result, there are multiple ways that various healthcare professionals try to resolve the situation. So PANS and PANDAS can be both a diagnosis of inclusion, meaning that unless you suspect it, unless you know what you're looking for, it can very likely be diagnosed as a mental health condition. Very often, anxiety disorders, obsessive compulsive disorder, anorexia, these diagnoses are made in children without realizing that there was a sudden abrupt onset after something else that happened. And so it's a diagnosis of inclusion. It's a diagnosis of exclusion also, because to be able to make this diagnosis, you have to be able to first rule out other organic causes. You have to rule out whether a child has OCD because of genetic conditions, whether they have major depressive disorder going on secondary to environmental, social, psychological factors. And then, since there is disagreement about the diagnosis, we don't have any diagnostic tests also that are gold standards for this diagnosis. Most of the tests that we have are tests that are arrows or that point us to the diagnosis. So yes, we can do viral titers, we can do streptococcal titers, antibody titers, we can do antibodies to various infectious triggers like mycoplasma or Lyme's, or infectious mononucleosis, or Epstein-Barr virus, herpes virus, influenza virus. But those tests tell us that yes, there has been an infection, but those tests don't tell us that there has been, and that is the root cause of the problem. So once again, the lack of certainty actually splits the whole scientific community. The state of literature is evolving. We have some literature now about this, and more literature is coming out as this is recognized as a valid condition, and actual studies happen on this valid condition. So still in progress. One of the things that I wanted to also emphasize was what is sudden, and this is also a huge debate that. A 12-year-old who presents with obsessive compulsive disorder is who has had some obsessive compulsive disorder symptoms even prior, is considered not as sudden. So let me tell you a little bit about it, and I'll borrow an example from a condition that is very well studied, multiple sclerosis. So in multiple sclerosis also, you have a pattern in which disease progression happens. So very similarly in PANS or PANDAS, there can be an initial insult to the brain, which results in sudden change. And then when there is not enough recovery, the change that happens does not recover fully, and people don't come back to baseline. So they remain with a slight problem for a continued period of time. Pretty much like MS. And the next time the same change happens, it happens and things become a little more worse, and they improve a little bit, but not too much. So after 10 years or so, you have a child that is continually starting to deteriorate, and a person who looks at the child will not say that this is a sudden kind of a deterioration. So sometimes if the initial infection is missed, if the initial suddenness is missed, then people often say that a child who has had a slow deterioration does not belong to that sudden class, does not meet criteria for the two major symptoms that we talked about, the obsessiveness and the anorexia, and they are told to be having some kind of a psychiatric illness rather than PANS or PANDAS. Again and again, I have met with parents who have had a lot of difficulty with interactions with healthcare, and part of it is that the lack of time between a patient and a provider. This lack of time can inhibit some of the providers from actually doing some of the research behind it. So when a child comes in who suddenly has this problem, it is far more easy to reach for a diagnosis that is convenient, will save time, will explain things, is well researched, than looking for a true answer that might suit the individual needs of that child or that parent or that family. And to some extent, it requires a lot of research. And even while doing research, there's a lot of conflicting opinions. So there's lack of clear guidelines that how do you diagnose? And even once you diagnose, then how do you treat? How do you investigate it? And because of this, there are these medical legal liabilities that various healthcare practitioners are faced with. That they have to treat something that is not documented and is not part of guidelines advocated by, let's say, American Academy of Pediatrics. Though, on a bright note, American Academy of Child and Adolescent Psychiatry has now started recognizing this after the excellent work of Dr. Swedo. So because of all of this, the parents usually feel a lack of support. One of the studies indicated that took about 4 to 5 visits for parents to actually be acknowledged by a healthcare provider that PANS and PANDAS was something that was going on. So parents usually feel that this condition exists before physicians do. And parents usually feel a lack of support because of this, because they're going to their physician taking their problem, and then they feel that they're not heard, they're discounted on the perspective of the patient. They want treatment, they want something to help them fix things, but at the same time, on part of the physician, they're thinking that we don't want to do any harm, we don't want to treat something that does not have established guidelines, and And there's a strange dilemma that happens then, that the physician does not want to do any harm, but at the same time, not doing any harm also means not doing any good. And the patient says, what do I do now? So they take this child who was functioning perfectly fine, and they take this child, then basically the message that they're getting is, we don't know what to do with it, go find someone else to deal with it. And they go to an endocrinologist, they hear the same thing. They go to a rheumatologist, they hear the same thing. They go to a neurologist, they hear the same thing. So basically, they are being told, you are in charge of your own medical health, because we don't know what to do. We can't do any good because we don't want to do any harm. There is a lot of philosophical, ethical, related to bioethics debates about this. In a sense, because of the lack of evidence-based medicine, and because parents and families have to deal with this condition themselves, they start researching things, and there is cookbook medicine that happens, so to say, meaning that parents try to do the best that they can, but this is out of any recommendations, and sometimes it can cause problems, either because of lack of efficacy, or because of lack of safety. Even practitioners who deal with PANS and PANDAS, because of lack of clear evidence-based, patient-centric guidelines, have to come up with treatments that are based in age-old traditional medicine, which is it is excellent that we have something to turn to while science is doing its due process and coming up with studies. We do have tools for this, so there is hope, definitely, and we do have the support of herbs, we do have the supports of food, we do have the support of various immune modulating strategies, and also antimicrobial strategies. So in a sense, we do have hope, because we have health building strategies. We have what it takes to optimize health. We can improve our immune system by several things that are sometimes even holistic. And this is the purpose of my conversations, and we'll be talking to a few people who are also affiliated with us in our clinic, and we're going to be going over what is the conventional treatment guidelines that are being put forth. What are some of the nutritional and functional medicine approaches that are being recommended? What is a traditional Chinese medicine perspective from it, and what herbal treatments and how do herbs play a role in treatment? We also have a fairly good idea about some of the deficits that can happen because of PANS and PANDAS, and how do we, as a village that raises a child at school, for example, can support that child so that child continues learning, continues having a sense of self-efficacy, self-esteem development. What kind of accommodations do they need? And how can we, what kind of a psychotherapy is needed around that, with the family, with the child, with the sibling of the child, with not only the nuclear family, but the extended family also, because a child who's having problems is a ripple effect, and that creates a ripple in all our lives. And then I think in the last session we're going to be talking about integrating all of these various treatments, and that is what we do in this clinic. We integrate all of these different modalities. If you want to find out a little bit more about some of this, work that we are doing and this unique approach that we are trying to take towards mental health. You can find some more information at our website, integrativepsychiatryaustin.com. We look forward to continuing this conversation with some of the other practitioners.